Talk about safe intubation. You want to ensure that your intubation equipment is available, ensure that there is safety of your medical team with personal equipment for protection. Also, make sure the highest trained person is doing the procedure. Avoid excess bagging or aerosol generation. Also, assess for difficult airways, and you can do that through very simple tests like looking at the back of the throat. Also, consider a rapid sequence intubation, where you may need to give a sedative and a paralytic as soon as possible. And you may need to use something called a glide scope, where you're giving image-guided intubation, where with the help of a lighted laryngoscope with a camera, you can look at the vocal cords and easily put the tube in. And you may have to get a chest x-ray, obviously, after the intubation to confirm your position of your endotracheal tube. And also, if you're putting a nasogastric or an orogastric tube, preferably an orogastric tube into the stomach, you can get an x-ray to confirm that. So when you're on a ventilator, you sometimes need assistance. So you need to figure out, when do you actually need this assistance? Suppose you can't ventilate a patient, you have difficulty ventilating them. You need to assess the patient, assess the circuit, check the machine. There must be something wrong somewhere in the circuit. Suppose you don't understand why the alarm is going on. You need to ask for help. Have a contact number for an expert to advise you in your own ecosystem, where in a hospital, it might be an anesthetist, it might be a critical care expert. They may not even be in your own hospital. And try to use a remote video to show the waveforms if possible, as long as you have the correct privacy protection and confidentiality for the patient. If everything else fails, remember that you can always bag the patient with an ambu bag or a Bain circuit, and avoid, of course, avoiding, to be careful with the infection precautions. Now, one of the questions somebody has asked is about, can someone refuse to assist a doctor if personal equipment is not available? Now, we're not in a situation yet where there is a overload of a surge. We're not yet in a situation where we have to triage. But in those settings, you should actually sit with your own team where you will be working and have a plan in place what you would do in a surge. You need to have a plan in place what you would do in case there's a triage decision you need to make, that there's not enough ventilators, for example. I don't think that situation will be faced in the near future by anybody in our environment, because at this point, from my understanding, the number of patients is not excessive, as well as the number of ventilators is fairly adequate at this point, and a lot of recruitment for new ventilators has been made. So going back to the concept of when to ask for help, something called SBAR, which is situation, background, assessment, and response. So your question is going to be, why do you need help? So you're calling your consultant at 2 in the morning and saying, I have a patient who I'm unable to bag. 50-year-old lady, or if you take the case we talked about, the 56-year-old male with difficulty in breathing on a ventilator with ARDS, the peak pressure alarm is going on. I do not know what to do. My assessment is this patient has probably got a blocked tube because of mucus secretions, and my response is to try to suction, but it is not working. What do I do? So you call your consultant. You already looked at the patient. He's not getting oxygen. You looked at the tubing and you think there's a block. You're looking at the ventilator, the peak airway alarm is going off, and you're looking at the settings and everything looks okay. The pressure is good. Then you need to contact the expert. You could quickly show the waveform, a video of it, and they can say, it looks like a tube block. Go ahead and suction, or call for a bronchoscope, for example, to go in and suction it out, or you may have to take the tube out and put a fresh one in. These are all high pressure, critical situations where you need to practice. A course like this is something that will give you the mental framework to assess the patient adequately, from the ventilator to the patient to the circuit, to give a adequate rapid response to the situation. Assess all the parameters. Is the oxygen level adequate? Should you make the FiO to 100% while the problem is being corrected? And ultimately correct the problem and then get feedback as to why this happened. So there are some questions about the intubation in terms of which drugs are preferable for rapid sequence intubation. For a paralytic, you can use whatever is available, cisatracurium, vecuronium, whichever is available for you, you can use. Sedatives, including fentanyl, for example, or propofol are options, but it totally depends on whether you have access to these drugs, including etomidate, and all of these are important to look at. The next slide is talking about the key takeaways. Remember, ARDS is a situation where your lungs become stiff, your lungs require low tidal volume. You monitor your plateau pressure by using an end inspiratory pause. Talk about safe ventilation, adjust the ventilator to the patient. And once we get to